Okay, we go to structural, and I think one of the interesting studies was a study on Basilica, and we all know that Danny Dveer is a
proponent.
Is definitely a proponent, and he is also leading the VIVID registry. And the VIVID registry deals with patients with a failed bioprosthesis and how to approach TAV, a transcatheter aortic valve implantation in a failed bioprosthesis. Well, we all know that with certain bioprosthesis, there is a risk for coronary obstruction, and they developed the Basilica technique, which is quite a complex technique of what they call scallop, but basically it's leaflet laceration to prevent the leaflets to get in front of the coronary ostia. Well, it is quite a complex procedure, but you see that the adoption is gradually growing, although not as fast as you might think. And there is a reason for that, because it's quite laborious, and it seems to me that it makes TAVI a more complex procedure, whereas we are more, of course, focusing on simplifying TAVI as a procedure. What they did was they identified the 129 Basilica patients from that registry, and then they compared the patient demographics, procedural characteristics and outcome with the over 2,900 patients in that registry who did not get the Basilica. Well, first of all, the major conclusion was that if you do a double Basilica, because you can lacerate one leaflet but also two leaflets, well, if you do a double Basilica, that's a lethal procedure. Patients died. There was a mortality at 30 days of 1 in 4, 25%, which is enormous. Also, the major stroke rate was 9%. Also, quite worrisome. Single Basilica seemed to be more safe. The stroke rate was then again 6.4%, so that is definitely more than what you would expect, and a 2% coronary obstruction rate. That is also quite high, because of course coronary obstruction is not something that we see on an everyday basis. So still, he was also then matching the results with 59 patients who were deemed at risk for coronary obstruction, but ended up not having a Basilica. And then the results with Basilica were superior. Well, I think we need to take those results with a grain of salt, because a lot of selection bias there. And again, we are really talking about making the TAVI procedure more and more complex, and there are potentially alternatives. You know, and what we do in our practice when there are really low coronary implants, then we would prefer a transcatheter heart valve that is completely repositionable. For instance, the Lotus technology. So then you can avoid, you can see, watch what's happening, and if you end up with some kind of obstruction, you reposition the valve. And another, of course, solution might be the chimney technique, and we all know that the chimney is not perfect, but in certain situations it really can bail you out and prevent coronary obstruction.
Plus, what they obviously could not account for, despite the propensity matching, was the fact that in the Basilica arm there was a clear difference in the types of valves, right? Because in the Basilica arm, over 65% had valves with leaflets on the outer side, like the mitral flow, which was not the case in the arm without the Basilica. So how that will have impacted the findings?
Well, I think those kind of valves, those specific valves like mitral flow, are predestined for coronary obstruction, so those are not the best valves. So that would be in favor of the non-Basilica arm in this registry. But the major difference was that the STS score in the Basilica group was 4, whereas in the control in the non-Basilica arm was 8%. Totally different patient population. So how do you match for that? So let's be careful with Basilica. I think it's a very interesting technology, but it needs to be modified, in my opinion. Let's switch to the tricuspid space, a very interesting space, because we do see quite some patients with severe tricuspid regurgitation, and there's not much out there to help these patients other than diuretics. So we know that there has been good results with MitraClip in the mitral space, and Abbott has redesigned the clip technology to a TriClip. So a clip specifically for the tricuspid regurgitation patients. And there has been a prospective registry of 85 patients, and that has been presented at multiple meetings. So we had the primary endpoint of those 85 patients that were presented at PCR last year, EuroPCR last year, and then the first 35 patients with 1-year outcome were presented at London Valves. This year at EPCR, Philippe Lourdes presented 60-something patients with 1-year outcomes. So still not the complete cohort. They managed to get into the late-breaking trial session. And what they found was that the results are quite promising with, at a 1-year follow-up, in 71% a 2-grade reduction, which is significant. Another 16% a 1-grade reduction. And people claim that, you know, if you even manage to get some kind of reduction in TR, patients will do better. And I must say that the KCCQ, so the quality of life of these patients, was improving. Their New York heart class was going down, which is good. And they even saw signs of reverse remodeling. So the right ventricular dimensions were getting smaller, and also the RV function was improving. So I think a clip for tricuspid regurgitation is a technology that is destined to stay, right?
I agree.
Also,
relatively low risk, right?
Yes, it is. It seems at least a relatively easy procedure. But again, also let's not rush too far ahead of us, because in 13% of the cases there was no change in TR. 8% of the patients had a single leaflet detachment. So that puts some questions to the durability of the results. But again, I'm kind of excited, and especially because this technology is coming to the Netherlands, hopefully in Q3 of this year. So definitely we want to get our hands on it, because we also want to mention that during our TO meeting, Philippe Lourdes did a live case with this technology, and it looked straightforward. I mean, this is not something exotic like a Basilica. This is really something that will impact our clinical practice. The clasp with Pascal, that's a different technology, but also an edge-to-edge repair device. We're not talking now about tricuspids, we're talking about mitral space. John Webb presented data on 109 patients, 62 of them had 1-year data. In 50 patients, there was a sustained effect at 1 year. They all had less than moderate MR. They started with severe functional MR. And all these patients had also improvements in 6-minute walk tests, in KCCQs. So I think promising results. And he also mentioned that there is this randomized CLASP IDE trial underway, which is a trial that is randomizing patients to either the Pascal system or the big component, the big competitor, which is of course the MitraClip, and this is going to be a study with over 1,200 patients, and that's going to be interesting.
Yeah, I agree.
Do you think that because at this point in time, of course, Pascal can allow for separate grasping, that potentially is an advantage, I would assume?
I agree, but we also know that. How long are we doing MitraClips?
10 years.
10 years. Yeah. But the volume is slightly increasing, and there is a learning curve. And I would not underestimate the impact of the learning curve, because many of the operators will have a lot of, perhaps quite some experience with MitraClip. This device is not the same. It applies different maneuvering. Yeah, it has specific features, but I'm very curious. Yeah. Very curious.
Let's switch to transcatheter mitral valve replacement systems for severe mitral regurgitation. David Muller presented a 2-year outcome of the Tendyne device. As we all know, the Tendyne is a dedicated transcatheter mitral valve replacement system, but it requires a transapical access. He presented on 100 patients that were enrolled between November 2014 and November 2017. Mean age of the patients was 75 years old. The majority had functional MR. Results were quite good. 1 reoperation at 30 days for a paravalvular leak, and that was it. And then at 2 years, the stroke rate was 5%, a reoperation rate in 5%. I think the patients were improving in terms of symptoms and quality of life. But then there was the mortality.
Yeah, so 41% of the patients appeared to die within 2 years. So obviously this is a first-in-man study, high-risk population. But if you compare it to co-opt, 26% died at 2 years, and these patients were also very sick. So it's a new technology. I think it deserves some further study, but we have to be careful here.
Yeah. He also presented data, echo data, in 44 patients at 2 years. Well, none of the patients had MR. And I think in patients with poor ventricles, if you reduce the MR from severe to zero, that might increase the afterload, and that might also prevent, for instance, remodeling and all that kind of stuff, because the ventricle gets into trouble. So I think very important technology, and as a matter of fact, it's the only CE-marked dedicated valve replacement technology for the mitral space at this point in time. So we are definitely also looking forward to implementing it in our practice. There is also another interesting study that also related to the Tendyne technology. That was a sub-study or one of the nested registries within the Summit trial family. It was presented by Paul Saraja, and it related to patients with severe MR and severe MAC. A specific group of patients that we all encounter in our practice. What Paul presented was the first 11 patients who, of course, ended to be sicker than what you typically expect from patients with severe MR. So their STS score was more than 9%, but the procedure success was 100%. So only one patient required a plug for a paravalvular residual leak, and that was it. And the mean gradient was 4 millimeters of mercury, which is quite powerful in patients with severe mitral calcification. So I think, again, interesting technology, but in the setting of MAC, we typically use a SAPIEN valve, which is easy to implement in a transseptal approach. The limitation there is the dimensions. A SAPIEN 329, you can go to an annulus of 30. But that's it. I mean, I think we do encounter from time to time patients where a SAPIEN is just not a safe option. And I think in those particular patients, it might be good to have this alternative of a Tendyne, even though it is a transapical procedure. A transseptal transcatheter mitral valve replacement system is the EVOC. John Webb presented EVOC data from the compassionate use and early feasibility experience. EVOC is, we're familiar with EVOC because it was a device iteration from the cardiac Q device. Edwards acquired the technology, and now it is converted into a transseptal technology. And that is a big difference, I believe. Transapical approach in a ventricle that is dilated with functional MR, I'm not sure whether that is a durable long-term solution. The results in those 15 patients, quite impressive. Patients had either functional or degenerative MR. There was one conversion to surgery, but don't forget, these are the first experiences with this technology. We're talking about compassionate use as well. One need for a paravalvular leak closure plugging, also okay, and one LVOT obstruction that probably resonates to the fact, or refers to the fact that pre-procedural planning is very important in this setting, and there's also things to be learned in that particular aspect of the procedure. But again, patients did very well in terms of MR reduction. There was less than moderate MR in all the patients, no MR in 85% of the patients. So I think quite promising, and I look forward to this larger early feasibility study.
Me too.
The same technology, the EVOC technology, was also applied in the patients with tricuspid regurgitation, severe TR, and the results there were even more impressive, at least in my opinion. There was, I think, a total of 25 patients were treated in compassionate use setting. One patient needed a SAPIEN in the EVOC because the EVOC was implanted too deep. One patient ended up not receiving the valve, the EVOC, so it was retrieved. But in the other patients, the results were quite striking. 1 in 4 were non-responders, but the TR was reduced to less than moderate in 88% of the patients. And so with other, with other repair technology, I remember that experts are talking about, we're reducing from torrential to severe, or from torrential to massive. So these subtle changes might already be clinically relevant, and all of a sudden with a valve implant you reduce to less than moderate. So I think this probably will be a game changer once it is developed into a streamlined procedure.